I'm gonna turn off the lights so that the screen is a little better visible. Feel free to kind of move that. Have a hard time seeing it. Mark is going to start now, I guess. Go ahead, Mark.
Okay, perfect. So thanks everyone for coming. My name is Mark Benayoun. I was really delighted to be invited by Vim to come and give you guys a talk. I took this course, I guess, more years ago than I should admit out loud during a recording. But it really does feel like yesterday. Did my MD, PhD and graduated in 2012, and then went on to do radiology, nuclear medicine, neuroradiology, all over the country. Was in Atlanta and then Boston for the end of my training at MGH, and then took my first job at Wake Forest in the neuroradiology department and now nuclear medicine department. And I got really involved in a lot of clinical work, I think, starting with epilepsy from work I did with Vim. And so like in the radiology department, I tend to read most of the MRIs that are epilepsy related. I'm usually the imaging person who does the clinical conferences with neurology and the epileptologists. And then because of my nuclear medicine background, I'll do some PET imaging for finding an ictal focus. And so a lot of my clinical work has been revolving around things I've been thinking about ever since working with Vim. And today I'm actually going to talk to you guys about fMRI, which, for surgical planning for epilepsy cases is a commonly used modality for deciding where language might be so you can avoid those areas during surgery as an adjunct to sort of planning how you're going to operate on a potential seizure focus if it's a, focal seizure. So I picked that topic because when I was doing this course all those years ago, it was a pretty heavy mathematics course. And one of the things I love about math is you learn it for all sorts of different reasons, but then it has its applications, everywhere. So as your research changes, or in your clinical life, in my case, you come across some math embedded in some of the work that you do, and you sort of instantly have a better understanding of kind of how it works. And so I read like all the fMRIs at Wake, and I think part of that is because I feel more comfortable with what the processing pipeline is, for those images. And so I'm a little bit less tripped up by artifacts, and, I don't know, protocol them, sort of understand how they work a little bit better. So I'm hoping to share some of the lessons I've learned about that with you guys, and just to give you a sense of how, how my job looks and how the skills I learned in this exact course that you're taking have benefited me all these years later. So I took a note from Amber actually and decided to break it up into kind of 3 parts. The first part's on kind of basic intro to like MRI and bold signal. What is the signal we measure for an fMRI? Some basic physiologic principles. Most of you will know much more about this than what I'm hitting on with just basic neurophysiology, but I do it for because I give this lecture to a lot of the medical students where basic cellular neurophysiology is something they haven't seen in, since college. And then we'll go on to some of the clinical fMRI methodology. I've got at least one illustrative case of an epilepsy patient getting an fMRI, kind of what his looked like and how he was managed clinically as a result of the different imaging findings. And then I've moved some of the harder bits of the math related to this to the end. I'll briefly cover some of it in parts 1 and 2, but in order not to kind of derail the flow of conversation, I've moved the sort of heavier math to part 3 to see what kind of time we have left. And also, just to sort of spend some time on it without sort of having to go back and forth between a lot of equations and then reminding ourselves why were we doing this to begin with. So hopefully this flow feels better. And feel free to ask questions. We'll stop for questions along the way, but hopefully, again, like last time, this is super informal. So please just stop me, ask any questions you want. The more interactive and engaging, the better. So we're going to start out with part 1. I'm just looking like, what is fMRI? So the F is functional MRI, and MRI is magnetic resonance imaging. So this is a functional technique, and it's used to figure out information about where in a person's brain certain functions are located. So most of us have taken neuroanatomy, and, we can say that we've learned that Broca's area sits in the inferior frontal lobe in the language dominant hemisphere, usually on the left. You can sort of know that Wernicke's area sits in the posterior aspect of the superior temporal gyrus or supramarginal gyrus. But, that's a population comment, meaning that an individual with a brain tumor maybe in a certain location may have remapped language, particularly if they were young and had plasticity present. So when it comes to asking about an individual, where is language, where is vision, where are things we want to preserve if someone's going to go to surgery, having a way to sort of look at that individual is sort of crucial. And that's the role of fMRI in the clinical world. And in the clinical world, unlike the research world, the only indication really that gets covered by Medicare and Medicaid and reimbursed is essentially surgical planning to avoid key structures. And the key structures that they sort of look to avoid are related to language, motor, and vision. Those are considered the sort of eloquent cortices that you're sort of looking out for surgical planning. And I think, the applications of fMRI in research is actually, just largely surpasses those limited aspects. But for reimbursement purposes in a clinical setting, that's pretty much the scenario that you'll get. And when we get to our clinical case, that will be the indication for that person's fMRI. So I don't want to go into the hard physics of exactly what magnetic resonance imaging is and what it is about fMRI. And so I am cheating. I'm pulling the wool over everyone's eyes, but then telling you I've done it. So the basic thing we talk about in MRI, and it will apply to fMRI as well, is when you put the body in a very strong magnetic field of an MRI, like 3 Tesla or more, protons and the hydrogen nuclei and the various atoms that comprise the tissue of the body and the brain, in this case, will align their intrinsic magnetic moment with the magnetic field of the magnet itself in the machine, in the MRI. And then they actually end up precessing around this magnetic field. And so I wanted to at least define what precession means, even though I'm going to use a classic physical example. So it's not really the same as what happens in quantum physics, but the idea of precession is the same. And so the best example is this, which is a spinning top or a gyroscope. And if you can see the rotating movie, what you'll note is that there's a gold disc that's spinning about an axis of rotation, and that's just intrinsic spin. But then you'll notice that the axis of rotation is itself rotating in a cone shape. And so you can talk about the frequency of the intrinsic spin, which is actually quite high. And then you can talk about the frequency of precession, which is the frequency of the axis of rotation coming back to its starting point. And so precession is exactly that, a kind of motion where you have both intrinsic rotation about an axis, but then the axis itself rotates in addition. And so that's the kind of motion in a quantum physical sense, if you will, that happens with protons put in a strong magnetic field. And it's essentially the piece of the puzzle that we use to get data from an MRI experiment. So here's that here. And then the one key piece of information that we'll start with is this, which is to say that the frequency of precession omega of a proton in a magnetic field is directly proportional to the strength of the magnetic field. So if you put someone in a 3 Tesla magnet, you can calculate what you expect the precession frequency of protons to be. And if you have them in a 1.5 Tesla magnet, you'd expect that precession frequency to cut in half. Now, the thing is, it's going to be slightly different for different protons because they don't all feel exactly the same magnetic field. You might have a 3 Tesla magnet, and that's going to be a really strong magnetic field. But if a proton is sitting next to something else that's able to shield it from some of that full magnetic, the magnetic field strength, it might not feel the full 3 Tesla. It might feel a couple millionths less, of the magnetic field strength. And so it'll precess at a frequency that's minimally different than its neighbors who maybe are not as shielded, by something electromagnetic next to it. And it's actually, that's going to be the thing that we take advantage of, because as we move forward, we're going to ask the question, what is it in neural tissue that we're measuring with an fMRI? Is it, excitatory postsynaptic potentials? Is it action potentials? Is it neither of those? Is it something else? So the thing I want you to sort of take away from the first part is that anything that can affect the amount of magnetic field felt by a piece of tissue, that's going to have the ability to alter the precession frequency and the ultimate signal that we're measuring with MRI technology. And so this was an early original image from 1992 in the original PNAS paper, where they flashed the lights on and off in a room at certain intervals, 30-second intervals, and recognized that you could get some sort of signal showing up in the occipital lobes of a patient or of a volunteer, right where they have their primary visual cortices. And so it was the first set of imaging that showed that you could do something where you flash the lights on and off and saw a change in some signal in the brain that was presumably related to visual input from the lights flashing on and off. And so that was the first question, what is this signal? What can we learn about it? What are its neural correlates and how do we use it? And so that's going to be the beginning of fMRI, and we're going to branch out beyond vision to look at other task-based fMRI and how we do it these days. So I might move through some of these slides a little bit faster for this audience because you guys don't really need a basic reintroduction to action potentials and, voltage gated sodium and, coming in and efflux and depolarization. So we'll move through this. But you've got the action potential, then you've got, chemical synaptic transmission, IPSPs and EPSPs, and all of these are producing electrical signals. So what is it that's happening at the neural level that we think, fMRI in particular is measuring? And so for a long time, I think the field of neurosciences really kind of ignored glial cells, despite the fact that they outnumber the neurons, at least 8 to 9 to 1, maybe 10 to 1. We had a great talk on microglia, last class. And in this particular talk, when we start understanding the neurophysiology for fMRI, we're going to see that astrocytes are kind of a major in-between or major connector that helps associate activity between neurons and the capillaries that supply blood to the tissue, at that level, at the tissue level. And so astrocytes are going to be a piece of the puzzle as well. Neurons are going to play a part of the role, and we're going to see blood vessels do as well in this sort of glioneurovascular unit is kind of the term a lot of people use for putting them all together. And so this is a slightly more realistic drawing of what we think of the interaction is. So here's like a small capillary bed in red, astrocytes in gold. There are podocyte footplates contacting the surface area of the capillaries, a neuron kind of sitting in the cartoon in the background. And the idea here is that 95% of the vascular surface area of capillaries are intimately contacted with astrocytic footplates, which are all connected to each other with gap junctions and then communicate synaptically with neurons adjacent. So it's kind of a complex network. And you kind of know this is true in some sense because you know that as neurons become active, the sodium potassium ATPase that resets the membrane potential is ATP required. And so if it runs out of glucose, if it runs out of oxygen, if it can't produce ATP through cellular respiration, it's not going to be able to continue its function. So it has to have a way to signal local vasodilation in the capillaries in order to sort of recruit more oxygen and glucose that it would need to perform its function. And that seems pretty clear. The details, of course, are actually still not completely worked out. So this is a schematic that I took from a paper from one of the people I worked with when I was at MGH for fellowship, where he had wrote for clinicians a basic intro to some of the biochemistry that occurs between neurons and glial cells and vessels that correlate neural activity with vasodilation and need for blood flow. And so what I'll just show briefly is you've got this idea of a synaptic terminal of an excitatory neuron releasing glutamate, and it can bind both to neuronal NMDA receptors postsynaptically or metabolic glucose receptors and astrocytes and signal downstream. And so in the neuronal case, we know that there's a part of NMDA, which is, of course, sodium coming through in depolarization, but there's also the ability for some calcium to enter through NMDA receptors, and that calcium can cause a whole chain of intracellular cascading mechanisms that are calcium dependent, one of which is the endogenous production of nitric oxide. And if you ever think of the classic example where someone's having a heart attack and someone puts a little pill under their tongue, I mean, that's nitric oxide, a pill, essentially that releases nitric oxide into the bloodstream to vasodilate the coronaries for the heart to try and improve blood flow to the heart during a heart attack. So it's the same chemical, but this is obviously endogenously produced by neurons, which then diffuses because it's, nonpolar across the cell membrane and causes downstream vasodilation of blood vessels. And so this way you get local capillary vasodilation and recruitment of blood flow to map onto synaptic activity. And one of the things that happens when blood flow changes occur is you actually get an overcompensation. So you actually get more oxygenated hemoglobin coming in secondary to vasodilation than you do consumption of oxyhemoglobin to deoxyhemoglobin. So it's kind of counterintuitive. I think I would have probably guessed that areas that are using oxygen because the neurons are firing would show more deoxyhemoglobin. It makes the most sense, but as it turns out, we have such a good compensatory vasodilatory mechanism that actually the opposite is true. And you get a compensatory influx of oxygenated hemoglobin, which actually shifts the ratio when neurons are active, such that local capillary beds and local tissue will have more local oxyhemoglobin than deoxy because of the overcompensation effect. And even if we don't know all the details of MRI and magnetic stuff, we do recognize that hemoglobin at its core is carrying oxygen with an iron atom. And pretty much all of us know that that's a pretty strong magnetic atom. And so it may not surprise you to finally get to the bottom, which is that what we actually think fMRI bold signal is related to is the transition of oxyhemoglobin to deoxyhemoglobin, that you end up with an unchelated iron atom, which has a very strong magnetic field, and it can shield local protons pretty significantly, altering what they feel as a local magnetic field, ultimately changing their precession frequency in a way that's measurable. And so it was a lot of sort of discussion about physiology and biochemistry and physics, but the bottom line really is that as your brain needs more oxygen to do its job, you get more oxyhemoglobin, less deoxyhemoglobin, and that shifts the magnetic field strength felt by those local tissues. And so fMRI is really measuring a perfusion marker. And a lot has to go right for the neuronal firing to cause downstream change in perfusion to then be accessible to acquisition by an fMRI. And so for most people who are doing direct, patch clamping and are measuring directly neural tissue activation, this is very indirect. And you might even think like, well, what if there's a tumor sitting in all this tissue? Wouldn't it just destroy this complex biochemistry? What's the likelihood that an fMRI should really work in a pathologic setting? What if there's a bunch of edema and the nitric oxide can't diffuse through all the extra fluid? I mean, you would actually imagine, a priori not having tried the experiment, that there's no reason that fMRI should work all that well in a pathologic state. And it's kind of amazing to me how well it continues to work when we do fMRI experiments in patients with tumors, seizures, and all sorts of pathology that you would think would destroy such a complex process. And yet it seems to be pretty robust. So just to give you a sense of the magnitude, it's about a 1.5% change in signal related to this compensatory perfusion change when neurons are activated in a task. So, if we don't do any statistics or don't do any math, that signal is so small and the SNR is sort of poor a priori that it can be really hard to confidently find that signal in the background. And so we will get to some of the ways in which we overcome that. Before I go on to part 2, though, I just want to take a minute because I did sort of bombard you a little bit and just stop to ask questions about either the biochemistry, the neurophysiology, the physics of MRI. Any questions just about how the basic biology is allowing us to create a measurable signal and how that signal is not direct neural activation? Okay. Well, we're going to move on. Let me see if I can just check the chat briefly. Okay, so I don't see anything in the chat either. So we're going to go on to part 2. And I know that was a lot. So part 2 is going to be a lot less of the basic physics and biology and a little more just about clinical methodology. So this should be a little bit more straightforward. So I want to get you familiar with what we actually do to patients when we're doing these fMRI experiments now that we kind of have an understanding of where the signal is coming from. So we typically put a patient in the MRI scanner and we create what are referred to as these block paradigms. So let's say we want to test someone's language. We're going to set up about 4 to 5 minutes in the scanner where they're going to undergo repeated tests where there's going to be a control rest, which is going to be useful later for statistical comparison. And those could be like 20 to 30 seconds of rest. And then we're going to interleave alternating doing nothing as a rest and doing a task. For example, in the language task, we have a common one like sentence completion. So the patient might be looking at a computer screen that has a sentence with a blank. And the context clues of the sentence usually make the blank pretty obvious. So you might be something like, I don't know, I cut up meat for a living. My job is that I am a blank. And maybe you're thinking butcher, I hope. Otherwise, it got really dark really fast. but like a butcher or something, so the context clues tell you what the answer is. And so every couple of seconds for about 20 or 30 seconds during the task, they're going to see these blank sentences on the screen, and they're only going to think about the word that fills in the blank. They don't have to say it out loud. In fact, I often tell them not to, because head motion, unintended head motion with speaking, can cause motion-related artifact that I don't want. And so I just tell them, just think about it, and that'll be good enough for the machine. We'll know if you're doing it when we analyze the data. You can use verb generation or word generation tasks. That might be something like you show a letter on the screen, a W, and you just have the person think of as many words that start with that letter as possible. And I've even done it for patients who are less able to cooperate. So I've had patients, actually, we've done fMRIs on, who were sedated and intubated on anesthesia. And if you actually lighten the anesthesia just to the point that they're going to take out the endotracheal tube and extubate themselves, if you get just up to that edge but don't cross it, and just play passive listening, like a story being read in their native language, you can activate their language areas enough to often get a good indication of where their specific language areas are. For motor, it can be things like opening and closing your hand, like I'm demonstrating in the video, something like this. If you know functional anatomy really well, and you want to do something like, maybe you're worried about a lesion closer to some of the areas for like more complex motor planning, like SMA, you might actually have someone do something like this, which is like a finger opposition task where I'm touching my thumb to each finger in order and going back and forth. That's a harder motor task, and it engages neurons in other parts of my brain for a higher sort of motor planning. And so you do have some room to pick the task in a way that might be closer to a lesion that sits next to an area of function you're more interested in sort of probing. And obviously you can check the hand, as I gave it an example, the ankle, you can check, the mouth, and you can basically follow the homunculus essentially down the motor strip and have tasks to look at all of those in a patient. And then going back to the original, flashing a black and white checkerboard to activate the primary visual cortex is a really good stimulus for looking at that. And so that's what we'll do. We'll typically do about 4 to 4.5 minutes for each one of these tasks. And we'll usually do in total, 2 language, 2 motor, and a vision is what I tend to do. So it's going to be all in all under about a 30-minute scan, which works well for the throughput in the MRI machine in terms of the way we schedule patients for scans. And I would say the spatial resolution, we'll get into this in a minute, is usually can be between 3 to 5 millimeters for clinical work. And if you're doing research work where you can put someone in a scanner for a much longer period of time and not worry about clinical workflow, they can get down to even 1 millimeter. But nonetheless, we should say that, when you talk about fMRI, the kind of the best spatial resolution you get is in the range of millimeters. So, think about that relative to the spatial resolution of, most electrophysiology, even on network level electrophysiology. Probably better than surface EEG. I think surface EEG takes a much larger chunk of tissue to get a signal, but probably not as good as like subdural implanted electrodes. And then for temporal resolution on fMRI, we actually acquire a complete brain volume every 2 to 3 seconds. So our data points are the sampling frequency is about temporally every 2 to 3 seconds. So we're not sub-second resolution. And so there's a lot of opportunity if you're thinking about network, spatiotemporal dynamics for things like EEG. I was talking with them before the class started, to have a lot to say about missing temporal dynamics that we don't see, sub-second temporal resolution in classic fMRI. So I think that's a really interesting research potential to kind of marry fMRI with better temporal resolution ideas and sort of see what you can pull out of network dynamics that way. So once we've obtained our bold signal, and down here, this is an example of what it might look like. So you've got a bold signal. This can actually is the whole brain. This is a representative slice axially through the brain, but you would have the whole brain. And for every voxel at 4 millimeter resolution, 4 by 4 by 4 millimeter cube, you would have a time series over the entire 5 minutes where the patient was going back and forth between performing a task and doing a control rest. And so we have a time series data for each and every voxel, and the patient moves their head. And so part of what we do is collect time series data about head motion. So we know the X, Y, and Z translations, like shown here in the middle one, and we have the 3 polar angle rotations. And so we can get a full view of how the head moved. throughout the entire acquisition, and then we can go ahead and correct the images for motion correction. So part of the sort of pre-processing before we do any of the real modeling and try to pick out where the voxels are in the brain that were responsible for the task, we can do some basic motion correction. There's some slice time correction because the very first slice that you get is temporally a little bit earlier than the very last slice you get. And we tend to think of like the entire brain as being acquired at a single time point. So we have to do some slight mathematical correction for that. And then finally, spatial smoothing. We always use a Gaussian to spatially smooth the data to get rid of some of the noise. And a good rule of thumb is they, go anywhere from 6 to 8 millimeters or up to 3 times your voxel width. So for like a 4 millimeter, you could go up to 12, but tend to do better at about 8 to 10. And you can see what kind of the spatial smoothing does to the image, for example, in a representative axial slice here. So that's kind of the pre-processing pipeline before we really try to understand where these voxels are. And so this is going to be the only slide until we get to the math part that covers the basics of what we're doing next. So definitely, if I get to the end of part 2, stop and ask questions about this so that you're prepared for part 3. But here's the basic idea. So we know that if you flash, say, a visual stimulus and give like a delta input to the visual system, if you were to measure the fMRI bolt signal, which remembers a perfusion signal, it would look a bit like this. It doesn't immediately pick up as soon as you flash the light. It takes a little time for the perfusion change to work its way through that biochemistry and neurophysiology. It goes up, it comes down as the stimulus has already been turned off since it's a brief pulse, and it actually undershoots a little bit before coming up. So this is called the hemodynamic response function, and it's essentially an impulse response of the system to, in this case, the example is a brief visual pulse. And then if you go back to our task paradigm, it was designed to be about 20 or 30 seconds of performing a task and then control and then a task and then control. And so the way the task is presented is basically a square wave, of 20 to 30 seconds in interval for several intervals over a couple of minutes. And so if you, do a convolution of the impulse response function with this square wave from the paradigm, you would predict that a voxel in the brain that really was changing its bold signal with the task paradigm would have a time series that looked like this one here. It would kind of go up, have a little bit of a dip because of the dip in the impulse response, and then with a little bit of lag because of the non-instantaneous response to the stimulus, when the task stopped and they moved to the control phase, would sort of quickly diminish and might undershoot just like the response function would, and then come back and then alternate again back and forth between task and control. And so this is a really good example of the expected bold signal in a voxel in the brain that is associated with the task the patient's performing during these intervals. And so if you were to think, for example, let's say that whatever bold signal we acquired in a voxel in the brain is Y, then if it's one of the ones that's going to be part of the task, we would like to think that Y is going to equal some number times X, where X is this expected response function. And there's always noise in any real system E. So we would expect that if really the voxel's bold signal that we measure when we do the experiment, if it was really part of the task, beta, might even be 1. That would be the easiest example. And the output in the voxel that we see would look just like the ideal with a little bit of noise added on, right? On the other hand, say, for example, you're doing language and you pick a random voxel in the brain that we know has nothing to do with language, you wouldn't really expect it to go up or down with the task. In fact, you might expect it to just look kind of noisy and be pretty steady the entire time because it's not really showing any change related to the task because it's unrelated. In that case, beta would be more like 0. And that bold signal time series for that voxel that has nothing to do with the task would essentially just look like temporal noise, right? And there'd be no real connection. And so what's going to happen next, the way we're actually going to do this is we're going to go ahead and take every voxel in the brain that we have a bold signal acquisition for Y, and we're going to try to fit it to a model of what is the best coefficient beta that we can find that fits the data as best as possible, almost like a linear fit. And then ask the question, is that beta 0 or is it statistically significantly different from 0? Because if it's substantially different from 0, then we're going to know that it's related to the task. and it could be anti-correlated. There are some situations where, for example, like attention networks, they might, as soon as you start a task, they might anti-correlate and turn off, because instead of just being a general attention, they're sort of now turning off as you perform a task, and then they may turn back on when the task is complete. We tend not to do negative correlations clinically, but certainly in the research, that sort of thing is abundant. So for us, we're basically looking for a beta that's not equal to 0. That would tell us statistically that we found a voxel's bold signal that's related to the task and probably important. So here I've got some of that written out and just some of the details. So again, we've got about 4 minutes worth of data for the average task. Our sampling rate is somewhere in the 2 to 3 seconds range. And so that would leave us with somewhere in the 80 to 120 data points time series. So that's about how many points we're working with. And we have this one sort of time series estimate that would be the best, our best guess of what we think it would look like if it were involved. And then we have all the values for the different voxels throughout the brain. Now you could add other potential time series. So for example, I showed you on the prior task that we collect head motion. So we have a time series that tells that we know exactly how the head moved in the X, Y, and Z direction exactly at the same time that the patient was performing these tasks. Now, I wouldn't expect that the response or the bold signal that we get in a voxel would be related to the head motion, but if it were, I would want to exclude that and not count any of that towards my assumption that that voxel is participating in the activity, right? So you can have other regressors, is what they're called in statistics, like other time series that might explain some of the bold signal that you measured, but that you would want to know because you'd want to subtract those off and really understand the question about how much does the measured bold signal match this specific modeled response based on the task paradigm, as opposed to other regressors not based on the task paradigm. And those are often called nuisance predictors because you want to know if they're present, but they're not the one you're hoping to find. So, but they do change the math and they affect the value of beta that you would find for this regressor. So you have to include them. So. Okay, I'd like to switch now. It's still part 2. We're going to go into a clinical case, but I will give a brief moment just to see if anyone has any questions about the way the paradigm is kind of set up before I go on to a case. Okay, feel free to unmute and just ask out loud. I don't see anything in the chat, and I don't think I saw anyone unmute.
Yeah, I just had a question.
Yes, please.
This is in regard to the block paradigm slide.
Yeah.
You speak about the verb generation being the gold standard for lateralization. I was just wondering if you give some reasoning for that.
Oh, actually, I didn't. Let's see. I'm trying to go back on my slide. Did I say that on the slide? Hold on. For some reason on sharing mode. There we go. Yeah, I did write that. So I didn't know if you knew that or just asking. I don't know that we know why, but a lot of times what people will do, and actually I've seen some lately, some disagreement that maybe sentence completion's better. But we don't really know why, but there's a lot of things where you can do like MEG and you can do other sort of gold standard methods. Actually, the gold standard is intraoperative recording. So sometimes what'll happen if you don't know, let's say on an fMRI, what the answer is, where their language is, they'll often do a surgery where in the OR, they'll open up the skull, they'll wake the patient up in the operating room, which is a big surgery with the patient awake, and they'll actually electrically stimulate portions of the brain while the patient performs a language task. And it's a much more direct measure of the spatial localization in their brain of language. And because you're using a stimulus electrode, you are directly stimulating neurons rather than using a non-invasive perfusion metric. And so compared to the gold standard, there was a lot of early evidence that said, for whatever reason, you get more statistically significant activation when they're doing the verb generation task that correlates better with where we see compared to a gold standard like surgical isolation of the language areas than you do with sentence completion. The real answer to this is really complicated because both for sentence completion, if you think about it, you need to know what the word means. And so it's actually like a semantic language thing. And then when you're doing word generation, if I give you like a letter like G, you're just thinking of as many letters as you can that start with the letter G. And you don't have to know what any of them mean. You just have to know that they all sound with the sound that starts with G, and you get it right. And so interestingly enough, I think like phonological, that's called phonological language when it's more about the sound and less about the meaning. It seems like for Wernicke's and for Broca's, and I'll show some stuff later, those areas tend to be better stimulated by phonologic tasks than semantic tasks. And so if the gold standard is finding Wernicke's and Broca's, you're probably going to do that better with something phonologic, actually, than you will with something semantic. And so that's probably the reason that we see more of it with Broca's and Wernicke's specifically correlating with where they find it on gold standard intraoperative mapping. But there's been some questions lately about, yeah, if we're looking at the right thing, maybe the semantic areas are also important. So it's a bit contentious, but that's why I put that there. It was relative to the gold standard of intraoperative mapping for Wernicke's and Broca's. So in the, thanks. Any other questions? Because that was a really good one, actually.
How do you find your unit impulse response mark?
That's a good question. So it's pretty sad, but they, this is all stuff that was like done in adults a long time ago. And when you get software, like for example, clinicians, like we're talking, you know, among friends and doing some math together, but the average clinician, I mean, I couldn't give this talk, you know, honestly. If I do put this particular slide up when I give a talk and I spend 8 seconds on it. I just say there's a bunch of math here and we're trying to statistically figure out if the bold signal looks like what we would think. And physicians, you know, they wouldn't read fMRIs if they had to know any of this. Here at Wake, I read all the fMRIs, but most of my colleagues around the country doing fMRI who are clinicians only, there's like super easy user-friendly software that all of this is kept away. The HRF is like, it's in the software somewhere and it's not even changeable. So if you did a baby and you didn't even think that the HRF was appropriate, you'd have no way in this like user-friendly clinical software to go in and change the HRF. In research software, I'm going to talk about like SPM, I think later, because, you know, SPM is a fMRI analysis tool for research in MATLAB, which I like because of that. You can do stuff like that. But we, like in the clinical world, it's kind of sad. We just have like a pre-programmed gamma function that fits data, you know, from literature pretty well. And it's just built into all the clinical software and it's unchangeable. Which is kind of sad. In fact, a lot of this stuff in clinical software is so well hidden and often not changeable so that physicians don't get too overburdened by the bells and whistles. I bet when you were doing stuff with EEG and trying to decide how much control to give physicians and how much to take away so they didn't hurt themselves, it was probably a difficult thing when designing software for non-engineers. But I often suffer from this. And there are cases that I want to bring into off-clinical software sometimes and put into the research world so I can have more control. But it takes a lot of time to do that.
Thanks. I was afraid you were going to say that. I don't think we need to discuss that now, but I assume that in research people have used deconvolution to get some idea what it really is, isn't it?
That would be far better way to do it. And in the research world, 100%. People have done that. And there's even some stuff on trying to create HRFs for different age groups where people have tried to do like deconvolutions in different subcategories of patients and figure out like when should we have, you know, switch one, when shouldn't we? What I will say is, again, for all the issues that you would have, I'm just shocked how well this works in clinical practice. Because I think like you know, there's so many times where I'm like, there's no way this is going to work. There's so many potential sources of error with what we're doing. And yet you get a pretty good answer that for surgical planning is usable. Anyway, moving on to this clinical case, there's a 39-year-old. He's a left-handed gentleman and he has medically refractory epilepsy. So he's tried several medications and failed. And so they wanted to consider him for resective surgery. His EEG sort of looked like he had focal onset right temporal seizures. So they thought there might be like a lesion to go after surgically. But they wanted to figure out exactly where. They wanted to figure out what the safest approach was going to be. And so, you know, I get this order for an fMRI to understand a bit more about his brain function so they can figure out what to avoid and also to help decide what to offer surgically. So before I get into that, I did want to show this image. This is an image from a nice paper by this guy, Eric Middlebrooks, who's a radiologist, very smart guy. And he color-coded different parts of the brain that are known to be involved in language. And I just put this up to say that kind of the classic Broca's and Wernicke's that we're all sort of taught it sort of doesn't, it's not really the model I think that people who do this in their research think anymore. We found that, so just to be clear, so Broca's would be like this area along the pars opercularis, so the inferior frontal lobe. This area here along the supramarginal gyrus, SMG, and posterior superior temporal gyrus, STG, would be considered classic Wernicke's, classic Broca's. They're both in purple because they're more stimulated with phonologic language tasks. And in this particular paper, I won't go through all the details, but he shows like areas that have both phonologic and semantic, which are kind of like in blue, some areas that are purely semantic in red, some areas that are more about generating speech, onset in green, some areas that are more related to the written language. So I think people now have a much more distributed understanding of language and where the brain is processing all these things. At the same time, when I go to a neurosurgeon, all they say to me is, I just need to know where Broca's is and Wernicke's is, and everything else is, I'm going to take it out. I'm going to cut. And a lot of times patients are, depending on where, like if you take an inferior anterior temporal lesion, they don't seem, even though we know a lot of semantic language shows up there on fMRI and other correlative studies, they seem to recover pretty well. And so like, for example, anterior temporal lobectomy is a really common procedure for, medically refractory epilepsy, and they take out a huge chunk of the anterior temporal pole, which would include some of these areas, even if it's on the language dominant hemisphere. In fact, they take out anteriorly with the only concern that they don't go far enough posteriorly to hit Wernicke's or any of the optic radiations heading back to the occipital lobe for vision. And so it's interesting the disconnect between like all the areas of language that we know about from a research perspective, and when a surgeon has to make a decision to do something to help this person's medically refractory seizures, kind of what they're willing to do with a scalpel to try and provide more benefit, than harm. So that it's kind of interesting to me that, they really just want to know where's Broca's, where's Wernicke's. If you take out the SMA in patients, they will have a transient mutism. That's an interesting thing. So if you're going to take out something that's paramedian frontal in the area of the supplementary motor, you do have to warn patients that they will likely wake up from surgery unable to speak, but that will recover over the next several weeks to months. Otherwise, they wake up thinking that surgery went terribly wrong. But other than that, many of these areas can be actually taken out without necessarily developing a deficit, although sometimes people will. So anyway, going back to our patient, so a little bit of history. So he was 31 at the time, but he said that as far as he knows, he was having some staring spell-like seizures, started when he was 10 or 11. They occurred every other day or every day even. And just to get a sense of how bad they were, it's not often, but once to twice a year, they would go from being simple staring spells to full generalized tonic-clonic seizures. Patient would fall on the floor and have, tonicity and then clonic seizing. And then one time, for example, he was unloading boxes from a truck on the bed of a truck when he had one of these, and he didn't have time to lie down or do anything to protect himself. And then he suffered an injury where he landed headfirst from the bed of the truck, had a massive subdural hemorrhage, was in an intensive care unit for months. So just to give you a sense of the clinical, import of his seizure control, not responding to medicines. So and that was his situation. He did talk about a positive aura. He mentioned a burnt tire smell, which for physicians, they're taught to think about temporal seizure onset because a lot of the olfactory system goes into the entorhinal cortex and the temporal lobes. So people think that, if you're having a seizure anywhere near your mesial temporal lobes and you involve the entorhinal cortex, you could potentially have smells that are not really there. And so that's been described. Again, he didn't have enough time lag or time forward, but with the aura to protect himself. So despite having the aura, he still, is really unable to do anything to mitigate potential injury. And then he came to me as left-handed, but I will say I did give them this sort of Edinburgh handedness question, which asks, it's just a questionnaire and it asks patients like, which hand do you write with, but also like, which hand do you cut with scissors? Do you use a computer mouse, modern times? And you often find that people are not quite as one-sided as they think. And so when I did that with him, just to say he was actually almost 50-50, he was left-handed by writing, but he did enough things with his right hand that he was pretty ambidextrous. And the level of left or right-handed dominance tends to give you a pretest probability on the likelihood that language dominance will be on the left, on the right, mixed, that kind of thing. And I'll just say that ambidextrous people have the lowest pretest probability of having left language dominance, which is otherwise the most common, language dominant hemisphere for humans. And then this is an EEG. This actually isn't a snippet of his EEG because I couldn't get it off our EEG software, but this is a snippet of the report from his EEG interpretation. And he had 7 seizures that all had a right frontotemporal onset, and they were mostly T4 greater than C4. And I don't talk about this in a lot of detail, but basically T is temporal, C is kind of central, right-sided electrodes are even numbered, odd are on the left. And so this kind of looks like right-sided temporal, and frontotemporal or central temporal was kind of where the EEG was pointing to. And they wanted us to kind of think about that in the context of, where his language was and how much distance there might be between a resection and useful function. And then just because I'm an imager, the following slide and the one after this are just to give you a little bit of a flavor for other imaging that's clinically done in epilepsy, but that is not fMRI, just kind of an adjunct. So this is just a regular MRI here on the coronal. And the finding here is that this white matter on the right temporal lobe is a little bit brighter compared to how dark the white matter is in the left temporal lobe and how dark the white matter is throughout the brain. And so this was a sign anatomically that there's been some axonal injury in the right temporal lobe, which is not completely localizing of the seizure onset zone that you would resect, but goes along with the idea that there's been some damage to the right temporal lobe, and we're probably in the right neighborhood of the seizure onset or area we should be focused on from a seizure perspective. And then these 2 images are related to FDG PET, where you give a person glucose. And so this is a color map of glucose metabolism in the brain. And it's color coded with low levels of metabolic activity in black and high in white. And I don't know if you guys will appreciate this, but it's slightly yellower and less bright white in the right temporal lobe. And these are flipped. We always look at the patient's perspective. So I'm pointing to the left side of the image as I say right side of the temporal lobe, right temporal lobe. But this is a little bit less white than this side. It's pretty white back here on both sides, but as you come up to the anterior temporal lobes, it's not as white. So the right temporal lobe's metabolic activity is sitting about here. The left is sitting a bit higher, kind of up here. And what's interesting about this is the brain normally uses glucose. So if we were to measure anyone in the audience's brain on a PET scan, you use glucose normally. So your brain would light up with glucose all over the brain. But this patient was brought in between seizures. So they're not actively seizing at the time of this PET. And although during a seizure, metabolic activity goes high from ATP production and all that neural activation, interictally, you tend to find a quiescent hypometabolic state of the area that's involved in the ictus because of this resource depletion during active seizure. And so we can take advantage of the fact that the rest of the brain is highly metabolic for glucose to try to look for areas that are interictally hypometabolic as a sign of finding a seizure focus metabolically. So we have anatomic, we have metabolic, we have EEG with electrophysiologic, then we have this perfusion metric with fMRI. And so we're putting together all these different pieces of the puzzle. And then just one more quick anatomic imaging, and we'll get back to fMRI. Another adjunct that helps from a surgical standpoint is this, which is called DTI, and it's diffusion tractography. And so here, we've just done a quick map of an individual's white matter tracts that show how how you get white matter axons going from the retina to the optic chiasm to the lateral geniculate nucleus of the thalamus, and then back to the primary occipital cortex in V1. And so we do have ways clinically to image the white matter tracts because, for example, in the language situation, if you spare Broca's and you spare Wernicke's and you sever the arcuate fasciculus, clinically the patient wakes up mute all the same. So even though, so you need, for surgical planning purposes, you'd like to know both where language resides in terms of Broca's and Wernicke's, but you'd also like to have a clear anatomic delineation of the axonal connections so that you can plan for surgery, with both those pieces in mind. So this is a different methodology, and I'm not going to talk about the math of this, but just wanted you to know it's an adjunct and it's relevant for the whole process of surgical planning. So this, though, is typically what the fMRI results look like. So what we've done here, we talked a little bit about finding those voxels that look like they likely correlate with the task paradigm. So these are going to be those ones that have a beta coefficient that's not 0, saying that the bold signal in that voxel looked like the ideal waveform or the ideal time series that we would have expected for a voxel that's participating in the square wave task paradigm. And so all we do is essentially color code the p-value for a statistic that asks the question, how confident are we that beta is not equal to 0? You know, how confident are we getting rid of the null hypothesis that beta coefficient is 0? And the stronger it is, it's more yellow. And if it's on the border, it's more red. And so we just find those voxels, and that's what you're seeing here, just these spots in red and a little bit of yellow. And then what we do is, to get better anatomic understanding of where these are, we just take a standard MRI, a T1 weighted MRI with all its anatomic detail, and we underlay it so that we can see exactly where these 4 and 5 millimeter voxels that had activity related to the task paradigm were located, so that we can give precise spatial localization to the surgeon about where we think Broca's, Wernicke's, primary visual, et cetera. And so in this particular patient, it's not a lot of activation, but I saw a little bit kind of in both inferior frontal lobes. And ironically, this was one of the first fMRIs I read as a new attending at Wake Forest. And when I came to Wake Forest, they actually had stopped doing fMRIs because they said they were less helpful. And so here I was, like the brand new attending right out of fellowship, and I did one of these, and I said to them actually that I was kind of concerned that the patient had language distributed into both hemispheres, which is pretty rare. So the very first fMRI I read, I come out with an unexpected conclusion that our left-handed 31-year-old had language in both sides. And that matters, because if I would have said he just had it in the most common dominant left hemisphere, well, that would have been contralateral to the right side that we thought his seizures were located. And it would have essentially given the surgeon carte blanche to do a pretty big resection of his right temporal lobe. But now I'm telling them that I think it's bilateral, and you need to be a lot more cautious about doing surgery in the right temporal lobe. And so if I'm wrong, he's going to get a smaller surgery that may not have as much control of his seizures. And then I'm going to be the one at fault for having said that I thought he had language on the right side, which is uncommon. And so in order to test this, they did another test, which is what they were doing before I came, because they weren't doing fMRIs, but it's more invasive, and it's called a WADA, WADA. And I just want to tell you what that test is and what it showed to compare to our fMRI. So in a WADA test, they usually will inject a short-acting anesthetic that can turn off the function of a hemisphere of your brain. So what happens is a surgeon or an interventional radiologist will put a catheter into the internal carotid artery and feed it up the neck and get up into essentially the distal internal carotid artery that would feed the anterior and middle cerebral arteries of the entire hemisphere, right or left cerebral hemisphere. And if they're in the right side, they're going to inject this sodium amytal, and they're going to essentially anesthetize for a few minutes the entire right cerebral hemisphere. And the patient has this done to them while they're awake. And so you can test language just before you inject the sodium amytal, and then you can inject and then repeat the language tasks and literally measure the decrease in language function in the patient when you've transiently anesthetized one hemisphere of the brain. You can actually then let that wash out, let them fully recover, repeat the experiment on the contralateral hemisphere, and you may come out, let's say, with a conclusion that says language was relatively unaffected with anesthetization of the right hemisphere, but markedly affected with the left, and so this patient is left language dominant. The problem with this, of course, is that you are putting a catheter into their internal carotid artery, you're injecting an anesthetic, there's a risk of dissecting a vessel or causing a stroke if you should knock a plaque loose along the way that embolizes into the brain. And so it's not without its risks. It's invasive. Obviously, fMRI is non-invasive. And so I was quite lucky. The patient was also quite lucky. He went through the WADA test with absolutely no problems whatsoever. And it showed that he had significant language deficits on both hemispheres. And so that confirmed from their perspective what I had said, which was that the fMRI sort of indicated that he had distributed language across both hemispheres. And he had seizures at the age of 11, but he was adopted actually. And I think there was a discussion of whether he might not have had seizures much earlier in life that went undetected because they were mostly staring spells. And I think that's probably the case because, if he was able to distribute language to both hemispheres, my assumption is that that was a plastic compensatory mechanism, probably related to seizures that would have occurred young enough in life that the plasticity would have still been present. So my guess is it was probably younger than that. Anyway, there are some fMRI and surgical outcomes and pitfalls. It can be difficult to design some control experiments. What is the gold standard? We currently use intraoperative mapping, but that's not perfect either. You know, you can stimulate more tissue than you intend with a stimulation probe placed directly on the brain surface. I mean, it's, you know, all techniques have their flaws. So, you know, the question of which one to make the gold standard is always a bit of a difficulty. But in general, there's lots of research out there, at least from the clinical world, that suggests that surgical outcomes, if you take out a lesion that's, you know, a certain distance from where the activations are in fMRI, you can correlate that with improved clinical outcomes in terms of both seizure control in the epilepsy world and in terms of not developing post-surgical complications related to having inadvertently resected eloquent areas like language, vision, or motor. And then the other thing I just want to mention in the pathologic state, you know, this, again, we talked about neurogliovascular coupling, meaning that a lot has to go right for the neuron's action potentials and EPSPs, which I didn't mention, but EPSPs are the single neurologic best indicator of finding a bold signal. And that's, you know, I sort of said that when I said that it's probably the calcium coming through NMDA receptors that then causes local vasodilation. But that's the piece of information that most supports that that theory, that EPSPs tend to be the best correlative for finding the bold signal on an MRI. But anyway, so, you know, one thing that can happen is if you have neurovascular uncoupling where that whole biochemical pathway is disrupted, you might have neurons that are responsible for the task at hand, but because they're not causing vasodilation locally because of this uncoupling of the physiologic coupling from the pathology, you won't see it on the fMRI because the fMRI is looking indirectly at neural activation through perfusion. And so if you have that situation and don't recognize it, you might tell a surgeon, well, this area of the brain didn't light up on my fMRI, so it's not related to the task. Go ahead and cut it out. But if you cut out neurons that are obviously firing and responsible for the task and just didn't see the indirect perfusion metric to indicate that, they're going to wake up with a deficit. So there are some, you know, this idea of neurovascular uncoupling and false negative has to be really well concerned. You have to sort of think about it pretty hard. And there are some additional imagings that we can do, cerebrovascular reserve and stuff to kind of look for that and get a sense that that might be present before we send them to the OR for surgery. But I just wanted to make that kind of clear to highlight some of the pitfalls of using an indirect measure. I think that's my last slide for part 2. So I'm going to stop right here and just see how are we all feeling with this? Any questions about the clinical situation, potential research expansion of what I've talked about, basics before we go on to a little bit of the math underpinning some of this? Okay. Having said that, I'd like to talk a little bit about how we do it and a little bit about this regression model, which is essentially this thing about finding beta. How do we find beta? How do we know, you know, what is the best fit coefficient that we can take our bold signal and say, you know, if we took our ideal model signal that matches the task paradigm, you know, what would be the multiplier that weights this towards telling us if that's what we got in our actual measured bold signal Y or not? And then the question is, like, if we don't get exactly 0, but a number close to 0, how statistically confident are we that that's just, you know, within measurement error? You know, is that really not, you know, 0? Is it really related or not? And so I want to start with like the simple example in math, which is like a simple linear regression. And then we'll sort of talk about this a little bit, and then we'll turn back to the slightly more complex fMRI experiment math. But you'll see there's a lot of, you know, a lot of similarity here. So to me, the classic example of simple linear regression is this example, like suppose we want to estimate people's height from their weight. And so we go out and we measure a bunch of people's heights. We measure a bunch of their weights. And so the, you know, the heights will be Y, the weights will be X. We've got some plot of their heights and weights. And you can tell just by looking at it that it looks somewhat like a line would fit the data pretty well. So what we want to do is make a guess. We want to guess that we can guess their height. And most literature uses a hat for estimates or guesses. So y hat is, this is going to be our guess at a person's height. It'll never be exactly their real height, the regular y, but it'll be a good guess. Now we're going to estimate that guess from the equation of a line where we plug in their weight. And now the only thing we have to do is figure out the ideal intercept and slope to get the equation of our line, right? And that's like this, right? So here's some real heights and weights. We're going to try to create a line where we're going to guess the heights from the weights. And we just want to figure out the right intercept and slope that overall across all the different people that we have heights and weights for, we do the best we can in minimizing our error in our guess relative to the actual patient's height, right? So that's the idea. And so to put that into math terms, what we would say is we really want to minimize. So we're going to take their real height. We're going to subtract off our guess of their height to figure out how much we were off by. And that's these small residuals here, how far we were with our guess on the line from where the real data point lied. So that's going to be that difference. We square it because sometimes it's positive and sometimes it's negative. So if you don't square it, you could wind up getting a sum that's 0 because some were above and some were below in a way that canceled. That's not really what we want. 0 should indicate that we got every point perfectly, which never happens. So we'll square the difference and then we'll sum that. And so that'll be a positive number and it'll give us some overall metric of how well our line fits the data. And the more we can minimize this difference, the better our guesses are to the real heights, the better our fit is. And so we want to find the B0 and the B1, the slope and the intercept that minimizes this. And so going back to like basic calculus, sadly, we remember how to minimize things. You have to take derivatives and set them equal to 0. So in this simple example, SSR just means the sum of the squared residuals. And the residual is that error between their actual height and the predicted height using just the equation of a line and their weight. So the difference would be their actual height, yi, minus the estimate of their height, which was fitted by a line, and knowing their weight. And so we're going to take that difference, square it, sum it for all the different heights and weights that we have, and somehow try to figure out how to minimize this number, find the B0 and the B1 that minimize that sum. And so if you were to take derivatives of this with respect to B0, set that equal to 0, take it with respect to B1, set that equal to 0, and then figure out what is the value of B0 and B1 that solves this math problem, you could figure out exactly how to calculate the best B0 and best B1 that are going to give you the slope and intercept that minimize your error, right? And that's what it would look like. And so you can find this in literature. This is exactly what Excel does when you plot your data. This is what MATLAB does. And then one other thing just to note is if you wanted to write the previous equation of a line, you could write it kind of like this with vectors. If you have a 1 here, that takes care of the B0. And if you were just to do this multiplication, you'd get 1 times B0 plus xi times B1, which is exactly the same thing as the equation of a line, an intercept plus a slope times x. So, you could write the classic linear regression as in a vector form if you wanted, but the math is all the same, everything that we showed here. So how does that relate to what we do with fMRI? So fMRI is a little different. The Y is not a patient's height. It's a measured bold signal. It's a time series. So now instead of being a single scalar number, like, 6'4", it's an entire time series of data, and it's the bold signal that we measure in that voxel. That's Y. X, now, instead of being a single number like the patient's weight that we want to use to predict their height, instead, it's the ideal time series that we got when we convolved the hemodynamic response function with the square wave for the task paradigm that governed what the patient was doing in the fMRI experiment. And so what we want to do now is ask the question, can we find a best value for beta, this coefficient that weights, to predict one time series from another? And we're doing it in a way that's linear, so it completely captures the sort of linearity that the simple linear model does that we showed before. And so if you write this out in matrix form, it ends up looking like this. We're going to just say that the measured bold signal in every voxel Y, so we do one voxel is a time series written as a vector. Each one of these is the next point in time, the next sample bold signal in time. And I think we said earlier on that'd be about 100 points or so based on our sampling frequency and the amount of data that we collect. And then X could be all the different predictors. You've got a bunch of ones at the beginning because those are the intercepts, essentially, just constants. And then starting with this very next column, this would be that predicted time series perfect model, sampled, digitized to be sampled at the same rate as the actual acquired bold signal for that voxel. You just put that there. If you do nothing but just include these two columns, that would be good enough. You could do the general linear regression and figure out beta. If you wanted to include other time series that could potentially influence Y, this is where you would do it. You design a larger matrix and you could put in, for example, the entire time series. The third column might be the entire time series of head motion, because you wonder if head motion might not be predicting some of what you measured in your bold signal that you don't want to falsely assign to the task, which is this column, right? And so what you would do is you would have a beta for this one, this column, there'd be another beta for the head motion. And when you solve this problem and find all the correct betas, you may take some of the value of beta away from here if you're able to fit some of the data with some of these other regressors. And so that would help you by putting those other motion and realizing that maybe the beta value for the one you care about for the ideal is closer to 0 than you thought, because without including these other motion related time series, you didn't capture the best model that could, that could explain all the data. And it might explain all the data, but then show you that you were over putting too much of the weight on what was coming from Y from the ideal that you're going to then say is responsible. So you would do this, and you'd end up with an equation that looks just like the previous one. You essentially just want to minimize the difference between the actual measured bold signal and your estimate of the bold signal. And your estimate of the bold signal is just X beta. The epsilon is just the noise. It's the reason that you're never going to be perfectly on the line. So now the question is going to be, how do we minimize the difference between the real bold signal and the best guess X beta, right? So Y hat is going to be X beta, our best guess for the bold signal we measured from these predictor variables, including, most importantly, the ideal time series that we're hoping really does a good job of predicting Y, so that we know that the task drove the bold signal that we measured in that voxel. And so you're just doing a minimum of the sum of the square residuals. But now these are vectors instead of numbers. And so everything starts to expand. Instead of being derivatives with respect to numbers, B0 or B1, you're taking derivatives with respect to a vector of multiple values for all the Bs, one for each of the regressors. And so it comes a little bit more complicated math, but you do it in exactly the same way. So the derivative equal to 0, solve for beta, and you end up with a really famous equation, which is this. And it says that the best beta values that fit your data is equal to this: X transpose X, that multiplied into a matrix, inverse that times the transpose of X times the vector Y. And this is really famous. If we have time, I'll show you how that works in MATLAB. And that gives you your best guess Y. Y hat equals X times beta. So if you calculate X times beta, now that we just figured out what beta was, it looks like this: X times beta, and beta we just solved for is XTX inverse XTY. So putting this whole thing together, you get your guess for Y based on the actual Y you measured. And this complicated mess is often just called H for the hat operator or hat matrix, because essentially if you multiply the signal you measured, bold signal you measured Y, by H, you get the estimate of Y. And so it's the matrix that turns a measured signal into the estimate of that signal. And so that's H. And H has some important properties that make doing math with it pretty easy. So I mentioned some of them here, and these show up in pretty common math texts on statistics of linear and multilinear regression. So that's why I kind of mentioned it. But one thing is that if you flop the rows and columns of H, it's the same, which means that H transpose equals H. And in the math world, they call those symmetric matrices, and they have all sorts of nice properties that you can take advantage of for doing math with all these things. And probably under the hood for most of the software that are doing these calculations are taking advantage of all of these properties to make it easier. So the next thing I would say is, if you wanted to know the error, how far are we off with our prediction, you would look at the bold signal minus our best prediction. And this error should be small if the voxel was part of the task, but could be really big if it's a voxel that had nothing to do with the task. because remember, we're trying to estimate based on it, assuming that it's going to look like the ideal signal that was participating in the task. And so you can calculate this as well. It's just y minus hy, since the h will put the hat on y, and you can calculate that out. And basically, as long as this is small, you've done a good job. If it's large, you've done a bad job. And you can calculate it. So the sum of squared residuals is just this. It's the, this is the error term, but this is the squared sum error term. You just, multiply together and add them up, which is doing the multiplication of the vector transpose times itself. And you can carry that math out and you get this. So just like you would do this in normal linear regression or have a computer do it for you, it's a pretty straightforward calculation, and it can tell you exactly how much residual you've left. And the smaller this is, the better you've done. So the more H looks like the identity matrix, the better you're doing. Similarly, like if you've ever done in Excel an R squared fit where you get an R squared value, you can do the same thing here. You can calculate an R squared and get a number between 0 and 1 that tells you how much of the variance of Y is being captured by Y hat, where when all the variance of Y is captured by Y hat, it means there's no leftover residual sum of squares and you've perfectly fit the data. And so this is an example of how mathematically you could take a signal like Y, a bunch of time series values, take the variance of that data and figure out with the sum of squared residuals, how much you were able to capture with your model. And as long as this is small, you've captured a lot with your model, and it's a good model to have an R squared value close to 1, just like you would look at the R squared on a simple linear regression to see how good your fit really was once you've calculated your intercept and slope. And so you can do that. Now, one thing that comes up sometimes is this idea of correlated noise. So a lot of the linear regression and multilinear regression assumes that there's no correlation in the noise. So in the simple regression model, there was something sneaky happening. We took different people, we took their heights, and we estimated their heights from their weights. Now, we took different people, right? What would have happened if we took the same person 25 times and 5 or 10 other people once each, and then tried to take, to predict their height and weight? We wouldn't have a very good independent sample of people. And our prediction probably wouldn't generalize very well. Once we started looking at more people, we would have seen the problem in not having independent data points in our initial experiment. And so, like, ideally, you'd want to pick height and weight from people that are really as independent as possible. If you pick height and weights from people in the same family, and it turns out they had a genetic correlation for short stature or different weight or whatever, you might not have a very good answer in the end that generalized to the population at large. And so we often have to think about that. When your data are time series, and each data point comes from a time series, the idea of having the points be uncorrelated from each other comes into the idea of having temporally uncorrelated noise. Is kind of the equivalent to making sure you don't pick the same person in your data twice when you're trying to get a random sample of heights and weights. And so you can actually look at your data and see, once you have your estimate, you can look at how far off you were, and you can look and see if the if the residuals in time are temporally correlated noise or not. And if they're temporally correlated, they'll have a power spectrum that's not flat, because uncorrelated white noise has a flat power spectrum. So you can test that theory. You can find out if you had accidental correlation, temporal correlation in your time series data. And if you do, then you have to actually correct for that. And so there are methodologies to look at the amount of temporal autocovariance in your data, and then they call it whitening because it's white noise when it's uncorrelated. So you can whiten your data so that it won't have those correlations and it won't violate the basic principles for multilinear regression. So if you were going to do that, you'd calculate an autocovariance matrix, which in this case I'm calling V. And then there are lots of ways to do it, but the most common is to define a whitening matrix. That's the negative square root of V. And if you were to do that, remember the original equation was Y equals X beta plus epsilon. But if you were to just multiply through by W, this whitening matrix, because of this noise term, now you would notice that the correlation in the noise term with W added on, because it's the negative square root, it would end up, decorrelating the temporal noise. And so basically that doesn't violate any of the preconceived notions. And so you can keep W in there if you want. And so if you make the translations that Y goes to WY and X goes to WX. You can then update beta and update all the other parameters in the math on the previous slides. And this takes care of any potential temporal correlation in your data that you hadn't considered pre-whitening. And then you just whiten it. You can get values for beta, and then you have to ask whether or not beta is statistically significantly different from 0. And so basically the way we just do that is we know that assuming that it's uncorrelated Gaussian normal white noise, we can just calculate the expectation value of beta. And I'm just plugging in from the math previously what beta equals. And you can carry it out and kind of see that basically you get an unbiased estimate of beta. Basically, you're just saying that like whatever we get for beta is probably the real beta. And you can calculate the variance of beta, which is important because then once you know what the variance of beta is, you can calculate a t-test essentially. And a t-test is where you say, I've got a mean value that's a little bit from 0, let's say, but until I know the variance for that normal distribution, I don't know the statistical likelihood that this is slightly away from 0, or maybe if the standard deviation and variance are so small, maybe this is statistically many standard deviations away from 0 and it's significant. And so once you've got the variance for beta in addition to the mean, you can run a simple t-test and get a p-value that would tell you if the beta value, the best beta that you calculated from a multi-regression was statistically significantly different from 0 once you knew how much variation in your prediction of beta you would get. And the idea there is that if I brought the patient back and did the experiment again, did the exact same fMRI task, I wouldn't get the exact same bold signal the second time. There'd be some statistical variation. And so my beta value would be slightly different, when I calculated it that time. And we're never going to bring a patient back and do the experiment 100 times, but we do at some point need to statistically ask the question, if I did do it 100 times, what would the variance be in my measurement of beta? And that helps me know if my value of beta is statistically significantly different from 0. And then a small detail that you can look at, because I'm running out of time, you can add this thing called a contrast if you want to create more complex hypotheses, null hypotheses. So maybe you don't want to know if beta 1 is different from 0, but for research purposes, you might want to know if one regressor was as important as 2 more combined, or whether one regressor was not relevant at all, or whether, so you could put a standard form where you multiply each beta parameter by a different constant to represent this kind of complicated null hypothesis. And then the contrast vector becomes the vector of these numbers that multiply by beta. And then you can just put that into the t-value. And this would be the more general version of your t-test that included a contrast if you had one. And so this is how you would do more complex t-testing. And then again, you just color code your t-value, your t-statistic, or your p-values, which is equivalent. And then you overlay that on your t1 to make the image that I end up reading clinically. And that's basically it. The last thing I would just say is alpha values are tough. We often in research do p less than 0.05, but when you have, 100,000 voxels, p less than 0.05 is still 5,000 false positives. And so there's a whole methodology of doing family-wise statistics when you're doing a ton of statistical tests, and you still want to control that the overall error rate among all the tests doesn't exceed a certain percent. And so you can do some of that as well to make sure that you don't have a lot of false voxels when you're doing this many statistical tests at one time, one for each brain voxel. I think I'm actually out of time, and I know at the end I had to sort of move through the math a little bit more hastily than I might have liked. But feel free, if you're interested in it or you have questions about it, to shoot me an email. I'm happy to chat about all this stuff with anyone if they're interested. Any final questions or anything related to either of the 3 parts?
Well, I have a quick question and a big thank you.
Sure.
It was
Go ahead.
Fantastic. I mean, I have not, I mentioned that we started to look at fMRI in combination with EEG. So for me, this was a great introduction to fMRI. Your last point, that was something I was thinking about, the Bonferroni correction.
Right.
Have people done things such as dividing up their experiment maybe in 3 parts, have 3 solutions, and if you find, let's say, random effects because of your 5% significance level, the likelihood that you will find the same voxels erroneously is small, isn't it? So
Right.
Overlay of 3 separate ones could maybe tell you something. Is that something that people do, or?
Yeah, I bet in the research world, people have done that, subdivided the time series data, make sure there's no trends or drift over longer periods of time, and then try to do multiple analyses of the subsegments and then look for the parts that, don't change as a way of getting over that. In the clinical world, honestly, what ends up happening for me is I have a lot of a priori knowledge because, like, if you know the functional neuroanatomy, I kind of know where I should be seeing, roughly speaking, language activation, other areas of activation. So I can often, like, just manually and visually change my alpha value essentially and see, like, if I turn the alpha value, really insensitively, the whole, every voxel lights up and it looks like every part of the brain is responsible for language. And then if I turn it down really, really far, I could even probably set it down so, so stringently that I lose all the voxels that were really bright in Wernicke's area anatomically that I see on the image. So I also have this sort of ability to just visually look and kind of see, as I'm changing my alpha value, when I'm gaining stuff that looks completely nonsensical and when I'm losing what looks like pretty accurate, high statistically likelihood areas that match all the a priori knowledge I have. And so oftentimes I skip doing, from a clinical perspective, I would skip doing like the pairwise, and there's like false discovery rate. That's kind of one of the more common ways to do this analytically. False discovery rate and stuff like that. And I just set the alpha value based on what I think visually looks like it's going to give me the best images from my sort of knowledge. And that's probably the thing about fMRI that gets the most complaint from scientists. That sort of, it looks good like this, and I'm going to go with that. And then I'm going to tell the surgeon, where I think the areas are. But it gets, yeah. And again, like, it's one of these things that amazes me that it still works well. And the patient comes out and they're doing well language wise, and, and they have good seizure control. It's amazing how well it works, especially in the clinical environment. But in the research environment, I think false discovery rates are one of the better compromises. Bonferroni, just so you know, just tends to throw out too much real data. It just throws out so many voxels that are actually responsible for the task because it's such a stringent thing to take 0.05 and divide it by 100,000 t-tests and then set that as your new cutoff. It's just so low that you lose voxels that are responsible. Yeah.
Well, again, I think unfortunately, we are out of time.
We're out.
Again, thank you.
Yeah. Thanks again, everyone.
I'll be in touch, Jim.
Please do. And for